Ladies and gentlemen, we now begin Symposium 21 in Hall A, focusing on tackling the burden of NCDs in Sri Lanka, with insights into whose strategies, burden of NCDs and risk factors, and the strategies of the Ministry of Health. I am delighted to invite our chairpersons, Dr. Vindya Kumarapeli, Professor Pujitha Wickramasinghe on stage.
Let me introduce the first speaker for this. So welcome to this symposium on tracking the burden of NCDs in Sri Lanka. So there will be 3 speakers and then followed by a 15-minute panel discussion. So the first speaker is Dr. Angela De Silva, MBBS, PhD. She's the Regional Advisor on Nutrition and Health for Development at the Department of Health, Population and Non-Communicable Diseases, WHO Regional Office in South Asia. So she will be talking to us on WHO strategy for NCDs. And I learned that it's a recorded version. So we will now play the recording and then we'll go to the next session.
Thank you very much. Good day to everyone. Firstly, I would like to thank the Ceylon College of Physicians for inviting me to speak in this symposium. I must apologize that I'm not available in person, but I will try and convey the same message through the virtual platform, and I will be available for questions after the presentations. So my topic for the day is on WHO strategies for NCDs. And I will be focusing on particular areas of the strategies because NCD strategies are a vast area. So I'll be focusing on non-communicable diseases and the mortality data, WHO strategies and public health recommendations to address NCDs, risk factors, and focus mainly on 3 risk factors: obesity, diet, and physical inactivity. And then finally speak about actions to be considered by physicians or the College of Physicians to support public health strategies to address NCDs. So if we take non-communicable diseases, they are a combination of genetic, physiological, environmental, and behavior factors. And the risk factors include tobacco, physical inactivity, alcohol, unhealthy diets, obesity, which is an intermediate factor, and air pollution. Now, global mortality data for 2021 show that 43 million deaths are caused by NCDs, led by CVD deaths and then cancer and the others. 18 million of these are premature in people less than 70 years of age, and disproportionate numbers of premature deaths are from low and middle income countries, causing economic losses, lost productivity, and poverty. And of all NCD deaths, 73% are from low and middle income countries. The global NCD burden is projected to increase by 17% in the next decade, and LMICs are showing very slow progress in addressing NCDs, and this needs to be focused upon and enhanced. Now, what has WHO's role been? WHO has had a convening role in advocating and creating awareness, leading and setting targets for NCDs. WHO at a high upstream level has worked through the World Health Assembly and the UN General Assembly through to create high-level political commitment and mandates through resolutions, which in turn are non-binding commitments, but they promote policy alignment at country level. In addition, WHO also has committed to supporting the SDG Target 3 and the target on 3.4 on reducing NCD premature mortality from it. In addition, WHO also has tools, guidelines, strategies, policy documents, which support countries in order to address NCDs. Now, WHO also worked with countries to set a set of NCD targets which have the greatest impact on prevention and control of NCDs, and most countries have accepted these targets. So the targets range from management targets as well as risk reduction targets, and these are shown here. In the next couple of minutes, what I will be doing is focusing mainly on the risk reduction, but I will also very briefly cover hypertension and diabetes just to show the importance of health system strengthening. So what are the strategies at country level to prevent NCDs, prevent and manage NCDs. And this WHO focuses on 4 areas: prevention and risk reduction, detection, screening and treatment, palliative care, and surveillance. Now, for risk reduction, WHO has guidance to address unhealthy diets, physical inactivity, and alcohol, particularly important for low and middle income countries because of the cost savings that will be created by reducing the number of population that need treatment. So population-wide interventions, public awareness campaigns, supportive environments, and settings-based actions are part of the risk factor reduction, and we will be discussing that further down the line. Strengthening health systems is very important to enable early diagnosis, screening high-risk populations, and evidence-based, cost-effective, context-specific treatment, and particularly the importance of ensuring continuity of care through integrated service delivery models. Patient empowerment is also an area which needs to be focused on. Palliative care is a third component, and that is to improve quality of life through a comprehensive care plan, especially for life-ending diseases such as cancer and stroke. And these should be worked upon with multisectoral actions. Then monitoring disease risk burden and trends is very importantly ordered for policy setting, policy changes, for resource allocations. And one good example is a WHO STEP survey, which is done by countries every 5 years or so. Now, this is the only slide I will discuss, or the only area I will discuss hypertension management. And why I'm showing it is to emphasize the importance of scale up of continuity of care. This shows the hypertension care cascade and the diabetes care cascade of numbers of people in the region. So you can see that though 295 million people have hypertension, only 116 are aware, only 86 million are treated, and only 40 million are controlled. And this is very important considering the fact that more than 2.5 million deaths are attributable to hypertension in the region. And a similar picture for diabetes. Again, the emphasis should be on treatment and also continuity of care. And patient empowerment is also important in order for people to recognize that they need to have continuous care. Now, for the rest of the presentation, I will focus on the risk factors, on obesity, unhealthy diets, and physical inactivity. Now, in 2022, at the World Health Assembly, member states adopted a new resolution or recommendations for preventing and management of obesity, and this is known as the WHO Acceleration Plan to Stop Obesity. It comprises of the WHO technical packages, which are being promoted for countries, and also it highlights the importance of the different multisectoral actions through health systems, social protection, sports, education that are needed in order to implement these interventions such as fiscal policies, marketing policies, food labeling, and physical activity, as well as public education and awareness. Now, if we take unhealthy diets and physical inactivity, we can see that for Southeast Asia region, there's a high burden of disease caused by unhealthy diets and also by physical inactivity. The figure on the left is showing the DALYs per 100,000 population, and the red and orange areas of Southeast Asia show that the DALYs are much higher for this region as opposed to high-income countries. Similarly, 21% of the new and number of mental health conditions, I beg your pardon, the number and proportion of new NCDs and mental health conditions attributed to physical inactivity is 21%, and that is pretty high. And these are modifiable, and therefore the focus on reducing risk factors. This slide shows trends in thinness and overweight in children 5 to 9 years and 10 to 19 years in all the countries in the region. And you can see the trends of thinness coming down and overweight and obesity going up. Again, highlighting the importance of addressing overweight and obesity, unhealthy diets, and physical inactivity. Now, what are the key actions or interventions to promote healthy diets and reduce obesity? they have to be implemented from early life to adulthood. And a healthy diet has to be consumed from early life to adulthood. And a healthy diet, which consists of whole grains, vegetables, high quality carbs, and also adequate animal source foods, low fats, and and preferably minimally processed, will prevent all forms of malnutrition and reduce NCD risk. Not just overweight and obesity, but these will address undernutrition and micronutrient deficiencies, which are important for this part of the region. And in order to promote healthy diets and reduce obesity, there are two components of interventions that we promote. One is, of course, the individual knowledge, counseling, and so on, and other settings based like nutrition education in primary healthcare settings and so on. But this is not enough, because with this, you also need to improve food environment in order for people to be able to access healthy food. So restricting unhealthy foods and beverage marketing, food labeling, reformulation, sugar sweetened beverage taxes, these are all very important. And many of these are being implemented in Sri Lanka or planned to be implemented in Sri Lanka. It is also important to focus on the out of home or ready to eat food sector, the food vendors, and so on. This is an example of some of the aspects of unhealthy diets. You can see in the figure on the left that the global trends in sale of food products, cakes and pastries, confectionery, sweet snacks, going up. Though it's very high in some parts of the world, you can see a very steep rise in the Southeast Asia region countries such as Indonesia and India, and Sri Lanka would be the same, though we don't have the data. Then convenience foods, like I mentioned, is a problem. Home cooked foods also can be a problem, especially those served in schools, hospitals, and so on. They may be high in sugar, salt. So in addition to behavior change, knowledge increase, we also need to bring in public food procurement policies which will limit the amount of, say, sodium or sugar which are added to foods in this kind of government institutions and settings. And the figure on the last is just to show the levels of mean population dietary salt, which is a key risk factor for hypertension, which is contributed to by all these unhealthy diets across the countries. And we can see even for Sri Lanka, the mean population intake is a very high amount of about 10 grams, when the WHO limit is shown in that red dotted line of 5 grams. And this figure is showing you marketing, television marketing aimed at children in Sri Lanka, and the volume of advertisements on high fat, high sugar, and salty foods that are seen. Majority of the foods that are marketed to children are unhealthy, and there's plenty of evidence, and this is just one piece of evidence for that. Now we come to physical activity, which is also very important. And there are so many benefits across a life course in terms of all-cause mortality, cardiovascular diseases, even in the elderly to prevent falls and physical function, cognition, and also very importantly, social connections. To create social connections and well-being, physical activity is very important. And over time, physical activity guidance from WHO has shifted from the concept of exercise to the concept of active living, where every move counts. So every move you make, every time you stand up, every time you walk a few steps, every time you sweep the floor, all that counts towards active living, and therefore reducing physical inactivity and sedentary behaviors. Now, the picture for Sri Lanka and Southeast Asia is not very good. And this graph on the left is showing you the estimates for insufficient physical activity insufficient physical inactivity in the different regions. And Southeast Asia region, you can see from 2010 to the projected 2030, levels are going up. And I've shown Sri Lanka on the right, where in 2010 to 2016, 27%, and now is 30%. It's time to really focus on these risk factors, and physical inactivity is one, in order to address NCDs. Now, what are the WHO strategies for physical activity? So WHO developed this and promoted this global action plan for physical activity. And again, it talks about the different components. So active societies, where you create positive social norms among people about physical activity. through communication campaigns, mass events, and so on. In addition, you also need to have supportive environments for physical activity. Then active people programs through schools in healthcare settings is also important. And then governance systems, the availability of data, relevant research is also one component. So all these components need to be looked at and implemented, policies implemented, and very often these are multi-sectoral policies in order to support physical activity programs. Now, what are the blocks to country implementation of diet and physical activity intervention? Lack of coordination among the different sectors, among different professional groups are a problem. Poor awareness, again, not only among the average population, but even among some professionals. Lifestyle barriers such as urbanization, technology, economic problems, healthy diets are more expensive. Then commercial determinants play a big role. So industry pushes unhealthy foods, they market unhealthy foods, they create misinformation, they create conflicts of interest among stakeholders and food industry, and these again lead to issues of having huge amount of unhealthy diets in the food environment. So lack of access to a healthy environment, not just for diets, but even for physical activity, even for smoking, having a smoke-free environment. These are very important. And these are some of the gaps that we see, and also data gaps, capacity gaps, and so on. So finally, to support ongoing national interventions, what can physicians or the College of Physicians do? I know that they're already involved in some of these, but I just highlighted a few points. So you can give leadership, advocacy, and policy engagement for multi-sectoral policies to promote healthy diets, physical activity, advocate for safe walking infrastructure and other enablers for physical activity. Can join and support stakeholders to design and implement national public health policies, strategies, protocols, and guidelines. The research and data is another area where physicians can strengthen the evidence base on diet, physical activity, monitor outcomes of increased activity and reduce sedentary behaviors, and also support routine facility level data, which could help towards improving policies. You can also train health professionals and workforce development and include and emphasize risk reduction interventions. In clinical practice and patient education, assessment of diet and physical activity during routine care, and not only assessing, but also having it in the patient records to track and encourage progress is important. Nutrition counseling, physical activity counseling is also key. Finally, collaborations, close collaboration with public health professionals and other sectors to promote overall NCD policies is very important and advocated heavily by WHO. I will end there. Thank you very much, and I will be available for questions after the session. Thank you very much.
Thank you very much, Dr. Angela. Now, I would like to invite Professor Anuradhani Kasturiratne. She is a professor in public health at the Faculty of Medicine, University of Kelaniya. Her research interests include epidemiology of snakebite, cardiovascular and metabolic diseases, and the economic burden of chronic non-communicable diseases. Over to you, Anuradhani.
Thank you, Vindya. Thank you, Chairpersons. I'm grateful to the Ceylon College of Physicians for this opportunity. I will be talking about what we encounter day to day. Nothing very hidden or secret. The burden and risk factors of chronic NCDs in Sri Lanka, as we know. I will be emphasizing more on cardiometabolic conditions and their risks. I have a bit of a conflict of interest here. I'm presenting some of the data from a study that I am part of. So my talk today will include some information about the NCD landscape in Sri Lanka. I will also be talking about the epidemiological burden, including mortality, morbidity, and disability-adjusted life years I will be talking about major risk factors, including behavioral, metabolic, and social risks of non-communicable diseases. I will touch upon emerging trends and high-risk groups here. And finally, a little bit about implications for practice and health policy, I think in relation to clinical practice as well. Sri Lanka is a country in transition. The impact of the demographic transition due to increased life expectancy at birth and survival across all age groups has led to the aging of the population as we see today. We are one of the fastest aging populations in the region. And NCDs invariably have come to dominate our disease profile in this background. It has also contributed to the epidemiological transition. However, infectious diseases also persist in the background, giving us a double burden of the disease. Trauma also adds up to this burden. If you look at the mortality from NCDs based on World Health Organization country-level data, more than 75% of all deaths in Sri Lanka occur due to non-communicable diseases. And the leading causes are ischemic heart disease, stroke, diabetes, and chronic obstructive pulmonary diseases, to name a few. Cancer, chronic kidney and liver diseases also follow close after. This is the same picture for both males and females, and that is a significant representation of the disease burden. If you take cancer burden, the annual incidence in Sri Lanka is about 33,000 cases and about 19,000 deaths due to cancer. We know that cancer has common risk factors to other non-communicable diseases, while there are distinct, specific risk factors as well. Cancer exerts a heavy social and economic burden on the population and families. If we look at morbidity and disability resulting from non-communicable diseases, we can use disability-adjusted life years to measure them. In the Sri Lankan context, disability-adjusted life years are dominated by cardiovascular diseases, diabetes, and stroke. With the rising cancer incidence, it is contributing to DALYs more and more. And all these conditions have a high burden of long-term complications. Disability-adjusted life years take into account both the years lived with a disability and years lost due to premature death. So the burden on the population is quite immense. If you look at the mortality in the premature age groups or the mortality in the economically active age groups, premature NCD mortality accounts for about 20%, and this is death during between 30 to 70 years of age. This exerts a huge impact on the productivity of the nation, as well as a burden on families and communities. So the figure here is about the unconditional probability of dying due to 4 major non-communicable diseases between 30 to 70 years of age in the period 2001 to 2010. The specific NCDs are cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases. This is from Ediriveera's paper, 2018, and you can see that cardiovascular diseases has demonstrated a larger, higher probability of dying at this age. According to World Health Organization country data for Sri Lanka, the probability of dying from any non-communicable disease between 30 to 70 years of age is about 14% for Sri Lankans. This is also in contrast to the global average, which is about 18%. So we are in a better position looking at the rest of the world. Nevertheless, our probability of dying due to NCDs is quite significant. If you look at the health system burden in terms of the economic aspect, we know that over 50% of hospital admissions in this country are now related to non-communicable diseases. This means we need long-term follow-up and recurrent admissions to care and maintain an optimal level of care for patients with non-communicable diseases. This also means there's a cost escalation for patients and the system both. The figure here from the National Health Accounts 2017-2018, comparing years 2017 and 18, you can see that non-communicable diseases account for the largest proportion of cost to the health system, amounting to about 30% on average. If you look at the household burden of healthcare in the same years, we can see that households are paying a high out-of-pocket expenditure for health. Because non-communicable diseases predominate in the epidemiological spectrum, we can assume that this large cost, out-of-pocket cost, is also largely being accounted by the non-communicable diseases. This places a heavy burden on families and households, even going to the extent of catastrophic health expenditure if the situation changes from bad to worse. So, to talk about from the burden to the risk factors, we know that behavioral risk factors, which are individual lifestyle-based, are the basis. So, tobacco use, alcohol, unhealthy diet, physical inactivity, and I also take psychological stress here because they are individual and lifestyle-based. Currently, based on estimates, about 30% of men in Sri Lanka smoke. And the prevalence of smoking is quite low in women. Again, about 40% of males report use of alcohol. Unhealthy diet, including high salt, sugar, refined carbohydrates, and even unhealthy fats, consumption is very common. Physical inactivity is reported by about 30% of adults, and stress is also mostly unaccounted in the current context. I thought of presenting some information from the recently available STEP survey and the Global Health Research Unit South Asia, of which I am one of the PIs with Prasad Katulanda. I thought I will present some of the selected information from there to this audience today. So I'm starting with what was presented in the STEP survey 2021. This is about smoking. The current smoking prevalence reported by men is 30%. And as we expect, the prevalence of smoking among women is quite low. However, they have looked at urine cotinine, which is an indicator of exposure to environmental tobacco smoke. And you can see about 50% of the men and nearly 10% of the women have also demonstrated positivity for urine cotinine tests. So this is findings from the Ministry of Health STEP Survey 2021, indicating that although smoking rates are static or even going down, exposure to environmental tobacco smoke, or so we used to call it passive smoking, that's quite significant. And this will have implications not only for adults, but for the children as unborn, as well as unborn future generations. So this is something we need to take as something significant in our move towards addressing risk factors. I have compared the reported rates of alcohol consumption in the STEP survey as well as the Global Health Research Unit study. All in all, what we see is about 40% people reporting regular use of alcohol. Again, the reported rates among women is very low. However, there's a significant reporting among men. This is comparison of the reported rates of consumption of fruits and vegetables. Now we are talking about a healthy diet. There are many proxies or different variables that we can use to get an idea about the status of diet. Undoubtedly, it's very well known that the diets are quite poor in the current context. So looking at consumption of at least 5 servings of fruits and vegetables is one of the ways of measuring the dietary quality. This is the percentage of people who reported consuming less than 5 servings of fruits or vegetables on average per day in Sri Lanka. So these 2 studies are 2 independent studies. STEP survey actually recruited over 6,000 people across the country. GHRU South Asia recruited more than 50,000 people across the country. And this data probably is for about 45,000 individuals, right? Although they are not close, they are both high. At least 50% of the people consume less than what is expected or what is recommended. Insufficient physical activity, again from the STEP survey. Females, this time, females have the higher prevalence of insufficient physical activity, as high as 40%. About quarter of the men also report insufficient physical activity levels. So if you look at basic behavioral lifestyle risk factors, we are in a bad place as a country, as a nation, as a population. So basic risk factors work on our metabolism, and we can have a look at our metabolic risk factor prevalence. So I basically looked at hypertension, diabetes, obesity. I did not look at dyslipidemia that much here. We did not have data. Generally, it's accepted that about 30% of our population, adult population, now has hypertension. Diabetes, variable, but at least 15% of the adult population has hyperglycemia. It can be higher in urban areas. Obesity is on the rise, again, more so among adult women. This is from the GHRU study. We have plotted the blood pressure. This is our blood pressure curve, systolic blood pressure curve, based on about 45,000 people. And the dotted vertical lines in the middle actually represent the mean values for that population. The unbroken lines show the mean values from the STEP survey. Because I didn't have the database of the STEP survey, I can only get the means for the STEP survey. So the means of our population means in systolic blood pressure, very close together. It's roughly around just above 120 millimeters mercury. This is an adult population between 18 to 70 years. And our blood pressure curves, actually, I think it's a little higher. And if you look at the diastolic blood pressure, again, the dotted lines are the means from the GHRU study, and the curve is for the GHRU study. The unbroken lines are from the STEP survey, roughly around 80 millimeters mercury. This is our blood pressure distribution. This is an island-wide representative sample, including more than 50,000 people. At least 45,000 people are depicted here. So based on both studies, if you look at the prevalence of hypertension, now we have come to the mark of 30%. Adult prevalence of hypertension is exceeding 30% in Sri Lanka. So this is based on a systolic blood pressure over 140 millimeters mercury or a diastolic blood pressure over 90 millimeters mercury, or being currently on medication for raised blood pressure. A person who reports that he has been diagnosed by a doctor to have hypertension. So quite reliable. This is what we need to expect. Hypertension is also a risk factor for many other metabolic endpoints. Therefore, this is a significant level of blood pressure prevalence to take action. If you look at the diabetes prevalence, I have only data from the STEP survey. It's as high as 14.5, 14.7%, close to 15% in the general population of adults. Again, a plasma venous value of more than 126 milligrams per deciliter, or currently on medication for raised blood glucose. Looking at the body mass index of our population, in both studies, both the GHRU South Asia and the STEP survey, the mean BMI was quite close. Our mean BMI is still high in terms of the Asian cutoffs. Among women, it's about 25.3, and among men, it's 23.9. So we are an overweight and obese population in terms of this data. If you look at the categorization of people based on BMI, you can see that if we use the Asian cutoffs, we have a large proportion. Maybe 70% of females, or at least 60%, will report to be overweight or obese. If you use the global BMI cutoffs, the situation can ease out a little, but still it's very high. So these are the risk factors probably on which we need to work on, both in the preventive as well as clinical setting. Finally, the self-reported prevalence of the conditions that we are interested in: cardiovascular disease, diabetes, dyslipidemia, and hypertension, based on the Global Health Research Unit data. We all know that all these conditions are underdiagnosed or undetected. For a prevalence of 30% hypertension, only about 20% of the people are aware that they have hypertension. Next, I would like to talk a little bit about social and environmental determinants of non-communicable diseases. We already mentioned aging of the population. More than 20% of our population will be over 60 years of age by another 5 years. This means non-communicable diseases will be a significant problem for us more than today in the future. Urbanization is also related to sedentary work, psychological stress, unhealthy diets, many other risk factors that may be behavioral. And there are socio-economic inequalities in the distribution of risks as well. I would just like to highlight some findings on the environmental and social risk spectrum from our work from the Global Health Research Unit. The first study on food environments and obesity, published in 2022, this study used geospatial analysis to look at unhealthy food environments and its association to obesity in the population. So it showed a marked significant association between living in localities with high density of unhealthy food environments and obesity. This also had a clear income and sex disparities in risk, the poorest being at the highest risk. The second paper on income inequalities in NCD risks and care, there's a strong income gradient in NCD risk factors across more than 200,000 adults living in South Asia. There are inequities in preventive care service receiving, and lower income groups are found to be less likely to access both preventive and curative care. The last paper on tobacco and alcohol zoning compliance is about zoning laws for tobacco around schools. And the study revealed widespread non-compliance with zoning laws around schools and gaps in policy enforcement leading to higher youth exposure. This is despite having regulations and policies in practice. Implementation is a challenge, and we need to think about implementation of the very good policies we have put down in context of these problems. So as an overview, there are structural drivers of non-communicable diseases like obesogenic food environments, inequities, and weak regulation. And policies must address environmental, socioeconomic, and regulatory determinants of non-communicable diseases simultaneously. There's a trend in risk factors which shows rising diabetes, rising obesity, if we look at the data from STEP surveys across the last 10-20 years. Although tobacco use has plateaued, there's increasing alcohol consumption, especially considering the younger age groups. This has implications definitely for clinical practice as well. There is increasing multimorbidity. I'm sure you see this every day. This gives rise to a need for polypharmacy and also adherence to medication, challenges related to compliance, and therefore early screening, risk stratification, and management is essential. What are the implications for health policy? We talked about WHO's cost-effective best buys. We have the current NCD policy. I'm sure Vindya could endorse this National Multisectoral Action Plan for Prevention and Control of Non-Communicable Diseases, 2023 to 2027. It's a comprehensive policy document. We have to look at gaps in implementation and intersectoral action and support collaboration to make it work. So the call for action is strengthen primary prevention, scale up screening and early detection, address underutilization of services at the periphery, then multi-sector collaboration and the role of the physician for advocacy, leadership, and clinical integration of preventive, promotive, and curative services. I would like to conclude, ladies and gentlemen, non-communicable diseases dominate Sri Lanka's disease burden, and it's driven mostly by modifiable risks. We require integrated clinical and policy action to address the problem of non-communicable diseases in Sri Lanka. Thank you very much.
Thank you, Anuradhani. You may join the panel. You come here. So I think we got a good overview about the status of the Sri Lanka on as far as NCDs are concerned. And we heard about the WHO overarching strategy. And I think Dr. Samiddhi will speak to us on strategies of the Ministry of Health and how can physicians complement. Dr. Symposium Samarakoon is a consultant medical administrator, currently serving as the director of Sri Lanka National Non-Communicable Disease Program. And she's also works as the plays a role as a national coordinator for disaster response and acting deputy director general for education, training and research at the Ministry of Health. Over to you.
Thank you. Good afternoon, Chair and all the participants of this symposium. So I think we listened to two very comprehensive and informative two presentations previously. So I think as the director of the non-communicable diseases, my role is to talk on the strategies of Ministry of Health in combating NCDs and how do physicians complement for these NCD strategies. So before going into the main discussion, I would like to discuss about the current picture. So it's very pressing area, these non-communicable diseases in our modern health care. So as mentioned in the previous two presentations, it is globally, this silent epidemic contributes 70% of annual deaths. So here with the WHO data, you can see from 2000, how the percentage of deaths due to NCDs are increasing from 61% up to 74%. So currently the country, Sri Lanka, is working on 4 main areas on NCDs, namely the cardiovascular diseases, cancer. We are to start the chronic respiratory diseases and diabetes. We have already started so many programs. And there are modifiable as well as non-modifiable factors in which we are happy to have these modifiable behavioral risk factors where we are hardly working as a directorate or the directorate NCD or as the Ministry of Health, which was mentioned in the previous presentation as well. The tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. We saw how dangerous the situation through the previous presentations. So here it is physicians, especially who are in primary care, are at the front line of this healthcare system, and they have to play a pivotal role in combating this epidemic. So when it comes to our home or the Sri Lanka, the situation is worse, I would say, with current situation. Global statistics says it is 70% of deaths contributed to the NCDs, but according to our statistics, it is more than that. 80% of deaths in our country are due to non-communicable diseases. So according to our analysis, the main contributing factors, aging population in Sri Lanka, we have a rapid aging population who are very susceptible for non-communicable diseases. Urbanization and sedentary lifestyles, of course, we know most of the people or the public who are working in different areas, they just come to the office by a vehicle. They are seated there for more than 8 to 9 hours, then go by another vehicle. They have no time for exercise to make themselves active. So majority of them are having a sedentary lifestyles. So similarly, with this urbanization thing, they eat processed food, which are very high in salt, sugar, and unhealthy fatty acids. And the last thing is we should not forget about the impact of COVID-19, how we faced it. Due to that, how the NCD care was disrupted and screening was delayed. So now we see the outcome of this disrupted care, NCD care, and the delayed screening by seeing so many complicated cases who are suffering from NCDs. So this is a key thing I think I want to highlight, the Ministry of Health, the strategic framework. So we have identified very correctly major areas as our strategies. So under these 3 strategies, the policy and legislative measures, we are going to identify the guidelines and how we are going to enforce these identified mechanisms to improve NCD care. And second one is health system strengthening. We are working hard on this area with new primary care reforms. So I will discuss it in another slide. And public awareness and community engagement also have come into the picture in a different way now. So these 3 areas mainly cover our Health of Ministry strategies for the prevention and control of diabetes. So this is our policy. Policy and the National Multisectoral Action Plan. We have NCD policy, and with that we have the National Multisectoral Action Plan. So I would like to say it is not only the targeted activities in this action plan is not only the health strategies, but we have identified so many other stakeholders, the Ministry of Education, Ministry of Agriculture, Ministry of the Fisheries, and so many other ministries to work with us together. And we have mechanisms like the advisory committee meetings. We have steering committees chaired by the secretary, and finally the National Council for NCDs we have, where minister is the chairperson for the National NCD Council. So we have very well laid down mechanism through the ministry. And this policy is, or the legislative measures are aligned with best buys or the cost-effective interventions we were listening previously about the tobacco and alcohol control, salt and sugar reduction. The identified cost-effective interventions are included. And we have regulatory strategies for tobacco and alcohol taxation, which will make people away from those bad habits. And at the moment, we are planning to introduce plain packaging. That is, the single cigarettes will show some health warnings in that, to make this smoking non-appealing for people who are currently using. And food industry regulation, again, trans fat bans and front of pack labeling, we have already halfway done. And with that, the people, when they are taking food into their hands, they will be able to see those are high sugar, highly fat content. So they will be guided with our these regulatory mechanisms. So for the health system strengthening, as I said, this Healthy Lifestyle Center, Osua Divisayana, there are 1,025 healthy lifestyle centers around the country. So I would say it's the one-stop shop for all the NCD screening and treatment. They do the screening, they check most of the risk factors, they identify the NCDs, most of them. So these healthy lifestyle centers, one of the key system strengthening mechanism the government has adopted. So again, I would like to say, with the upcoming primary health care reforms, these centers will be strengthened, highly strengthened, with more facilities like drugs, equipments, and human resource. And in addition to these healthy lifestyle centers, there will be PCCU, that is primary community care centers, where the empaneling population will be 5,000. It will take more years, but the current government is targeting for this achievement. So this will be a very good initiative to combat NCD diagnosis, screening, and treatment, mainly the prevention part. And when it comes to the digital health, of course, the country is also again towards this target. So e-NCD registries, we have tried halfway, but we are to roll out with the current positive aspects the government is going to give us. So the with e-NCD registry, we will be able to track most of our data about the non-communicable diseases for us to take actions. And mHealth for patient follow-up, of course, now it's no more futuristic. It is now there in a few districts, where with this mHealth, people are getting messages into their phones saying that they have missed their clinic visit. And another new date is given through these mobile phones. So it is happy to say, so we have implemented this thing in 3 districts in the country, and yet to roll out for the whole country. And not only that, through this, actually, the titration of hypertension drugs and diabetic drugs are to be done, and successful projects are there in the Kalutara district through different NGOs. Public awareness and community health, engagement. This is where we talk to the heart and brain of our people. So we have so many mass media campaign like Eat Right, Move More. So again, Ministry of Health is together with the Ministry of Mass Media. So we are really getting support to develop so many key messages to air and get to improve our public awareness, and by that we will be able to get the community engagement easily. So without stopping from the mass media, we have identified some special programs at schools and workplaces like healthy canteens and wellness initiatives. So that is area where NCD strategies are laid down as a Ministry of Health, and especially the Directorate of NCD, but ground level is from the provinces through MONCDs and regional directors and provincial directors. So we'll now just see how the clinical frontline, the physicians powering our national NCD strategy. So actually we are working very closely with them, and they really power our strategies. Just to get the picture, here again, it's like tsunami, I would say. And here you can see after 35, both males and females, there is a sharp rise in percentage of NCDs. So this is the current picture of NCD, and it's a shared challenge. And again, this diagram, the second one shows the diseases which are contributed to contributing, the diseases which are contributing for this high sharp rise. So what are the scale of challenges? Definitely we know NCDs are the leading cause of mortality and morbidity nationally. So they represent significant burden on our healthcare system and economy. So even for the Ministry of Health, most of the budget allocation we are getting, the highest percentage comes for the NCD care. So these are the government commitments as I showed earlier. National NCD strategies and action plan is there. And again, we have focus on WHO best buys, taxation, public awareness and screening, which they are really guiding us on. The government strategies for non-communicable disease are there in our policies as sugar taxes, public health awareness campaigns and regulations on tobacco control. So while these top-down approaches are crucial for creating a healthier environment, their success ultimately hinges on a critical, often understated factor, that is the individual physician in the clinic. They are playing a bigger role. So physicians are not mere implementers of policy. They are active. They are complementary agents who translate population level goals into personalized, actionable care for patients. So they form essential human bridge between the government strategies and the individual health outcome in the battle against NCDs. So government is having a macro strategy and physicians are the micro interventions. Government strategies are outlined by WHOs, not only WHO, and many other NGOs, typically focusing on cost-effective interventions, aiming the entire population. Like this is done through, again, as I mentioned, the 3 strategic areas: legislative measures, public awareness, and the health system strengthening. So for that macro level strategies, physicians really complement. So how do they complement the legislation part? So we have the tax for tobacco, but it is the physician, how much tax we impose on them. It is physician who conduct the crucial 5A model: ask, advise, assess, assist, and arrange for smoking cessation. So without him, this won't be getting implemented in the society. And there is evidence also. This is Stead et al. 2013 has mentioned that 66% the brief advice from the doctor can increase quit rate by 66%. So this is a very high percentage. So even there are research evidence to show that clinicians have the role in implementing or getting these legislations done, active. The physicians personalize the risk, making the abstract concept of the government tax tangibly connected to the patient's own health, family, and finances. So again, this is the second area, complementing awareness campaign. So what I want to highlight here, how the physician's role. So physicians, however, provides, we can lay down, saying we can show so many posters, we can do so many awareness campaigns by saying just eat healthy. But physicians has a different role. As an example, if it is a diabetic fisherman, if he comes to the physician to get the treatment, he can tell him, what are you taking for your morning meal? And he can say, instead of your 2 slices of bread, you can take jackfruit or some lentils. So this will keep your blood sugar normal while you are away in the sea. So he can come to the cultural level, the socio-economic level of the person whom he is treating, and give them the better advice. So definitely, these kind of messages are very practical and sustainable for conditions like diabetes and hypertension. And there is again research evidence from Bennett et al. 2021, who talks, the research paper talks about this area. So again, early detection and secondary prevention is very, very important. Now we are focusing the whole health system on preventive aspect. These physicians, the government is focusing on the population high-risk people, but physicians are the linchpins of early detection and secondary prevention. And they are tasked with opportunistic screening. So nowadays, not only the people who are coming for the healthy lifestyle centers, physicians are instructed to do the opportunistic screening whenever he sees the patient. Even the patient has come to take treatment for the cough and cold, he's supposed to check the blood pressure, blood glucose, and BMI to identify the pre-diabetics or hypertension long before the patient becomes symptomatic. So this is going to be a very cost-effective thing for the government to save their money that are spent on very complicated NCD patients. Risk stratification. Again, without anything, they have this WHO CVD risk charts with them. With that, they can identify high-risk people. And again, it's a cost-effective method for the country's economic burden. And they have a role of titrating medications for statins and antihypertensives. So I don't know, with the STEP surveys, we found that most of the, even our population, it is 33% hypertensive. And among them, only 50% know they are hypertensive. And only 60% are taking drugs for their disease. Even out of those who are taking drugs, it is 16% is only having control over and hypertension. So this titrating of medication is very, very important area where these physicians can play a role. By again, this will contribute for the our country's preventive mechanism for NCDs as well as the cost effectiveness. So it reduces the future burdens on hospitals and emergency care by initiating and giving the correct management. So we have to shift from the episodic to continuous care. So NCD has a chronic nature, all NCDs, and we have to have a paradigm shift from acute episodic care to continuous holistic management. So physicians have a very important role to become the care coordinators and to shift this episodic treatment to a continuous care where they can't just see one patient once and let them go, but they have to arrange a mechanism to give them the continuous care with proper follow-up. So again, this is a chronic care models what they operate. And they have to create proactive care plans, encouraging patients' self-management and utilizing community resources. So again, this aligns perfectly with the government's goal of reducing hospital readmissions and complications. And this motivational interweaving, they do this kind of motivational interweaving, we call it. It is beyond prescribing. Physicians use this technique to explore patients' ambivalence towards change, empowering them to take ownership of their health. So this is by asking few questions rather than just treating them. So the physicians are leaders in having this kind of motivational interweaving in prevention. The patient-centered approach is far more effective than simply dictating instructions. So they have to take care and develop treatment plans for them. And advocacy and data collection, this is also a very important area. The physicians, they have to give us the data or the real current situation to take the policy decisions at higher level. So for the NCD STEP survey, they were there throughout helping us to develop a questionnaire, even the collecting data, analysis part of it, and even the preparing the report. So that is their routine help we are getting from them. And they are our ground level intelligence. So that's what I said. Through them, we can get the first-hand information about the current ground level situation. And this feedback is invaluable for policymakers to refine and adapt strategies. And not only them, the professional bodies like this, actually, even I can remember how these colleges, professional bodies, not only the College of Ceylon College of Physicians, even other consultants who are providing professional advocacy for the ministry programs to develop our plans. So challenges and pathways, there are so many barriers identified for them. We need to help them with different strategies. So as a conclusion, government strategies set the stage for combating the NCD epidemic, but physicians are the lead actors who bring the script to life. So their unique position of trust and their direct patient relationships allow them to personalize public health, motivate behavioral change, and manage disease program. So by recognizing, empowering, and supporting physicians as the indispensable frontline complement to policy, we can build more resilient and effective defense against defining health challenge of our time. So this is my final slide. So it's call to action. And government sets the stage, but physicians perform the play. So together we can, as administrator, together I invite them to work together so we can turn the tide on NCD. Thank you.
Yes, thank you, Samiddhi. Come over here.
Thank you, Madam, for elaborating on the government strategy. And actually, yesterday also we had a brainstorming of the local and expatriate and some international colleagues on particularly diabetes. And what we were thinking is like you all are doing a great job. Like, you all have made more than any other country would have done on this health screening, like the Sodivi healthy lifestyle centers. But I think the uptake is like the issue. So I know we cannot be a police state also, but whether there are some action that the government can take, making people mandatory that at least some categories like those who receive these benefits, like the, what do you call this, the presenter, Samurdhi Wage, what is the name of it? Aswasuma, the some categories to mandatorily, because we see some categories of staff like the pilots and various categories where they may need to maintain particular BMI based. I think we might have to move towards some degree of enforcement just if you are to take action.
Yeah, Prasad, just before answering, I think I'd like to invite the two panelists. Yeah, so let me invite Dr. Farrukh Qureshi, Medical Officer, Non-Communicable Diseases, WHO Country Office, Sri Lanka, and also Dr. Upeka Samarawickrama, Consultant Nutrition Physician, representing the Sri Lanka College of Nutrition Physicians. Yeah, so maybe Samiddhi, would you like to answer Prasad's question?
Yeah. Yes, actually it's very correct, the intervention you suggested, and we are planning for that. Actually, it is not the Aswasuma. We recently had a discussion with the Secretary of the Public Administration, Ministry of Public Administration. So that Secretary agreed to include this thing into the all government servants increment. So that is also a very good suggestion. So at once he was a bit reluctant, but we insisted on, and we convinced him how to get it done. So unlike those days, current ministries are, I think they are passively working on this area. So with that, we can initiate with the government servants. And we had a discussion with the Triforces also. They are also willing to include this thing, the BMI, and getting their regular checkups once a year. But only thing is, they ask us whether we have our facility to have this kind of program. So there are some positive as well as negative things to include this thing. But for this Aswasuma, as you mentioned, these people from the primary care, of course, we were not thinking about that. So since we are focusing on the primary care, and at the same time the Grama Niladhari is there, so with the help of those HLC staff, we may be able to start from that point. So regular, yes, checkups, the whole family. Yeah, that's a very good suggestion. I would try to discuss with our staff team, NCD team, and again with the relevant, the public admin people, and try to implement these things. A very good suggestion. Thank you.
Thank you, Dr. Samiddhi. I like to pose a question to Dr. Farrukh, but we have very 4 minutes, but you can maybe take 2-3 minutes. So I think Dr. Angela De Silva is also there joining online. Maybe you were a little late to come, but Angela very clearly described the WHO strategy for NCD prevention. And I know based on your expertise, I like to ask that she mentioned various risk factor related strategies as well as about the multi-sectoral action. Would you like to very briefly comment in now, even Dr. Samiddhi presented the fact that we have a national policy and a multi-sectoral action plan, but we know it's like we are struggling to implement. So maybe you can take 2 minutes to answer in terms of Sri Lanka, what are your recommendations to implement the multi-sectoral action to have a very successful NCD control?
Right, thank you. And I'm always glad that currently Government of Sri Lanka, Ministry of Health, and even this big community of physicians is now taking a lead in these discussions and really pulling it up in a way that this is the ownership that is required not only at one end, but at every end of the working domain of this health sector. Now, the particular answer lies, ma'am, in two references. One is we think that multi-sectoral action has become a bit of a buzzword, saying because every country is doing it. We have our data that recently is even showing that more than 70% of the countries have some sort of mechanism where they say they are working. They might have committees, and we do have. They have coordination bodies at different levels. But what is missing is a targeted approach. And that's probably, as I mentioned, that it might be as much micro as ma'am was mentioning, that it can be just 1 or 2 particular interventions related to diabetes, provision of medicines. But it can be considered in a more larger frame as well-being or prevention or full aspects of care provision. But neither of these would work unless the target is defined by some goal. And I would say that the recent assessment, even I think a day before, on 10th September, there was a new publication, Lancet published the mortality review of the last 2 decades, the trend, reduction in trends. And I won't go into the details, but the one clear aspect was that the recommendation remains the same, that the multi-sectorality is still missing. And I sometimes feel that the way forward practical would be to keep it, for Sri Lanka, I would recommend take it like obesity reduction or take it as diabetes, as a few areas that you can divert the attention of the multiple sectors rather than openly asking only for NCDs. And that's something that will not work unless we request a targeted frame of action for all the sectors involved.
Thank you, Dr. Farrukh. May I ask another question? Since Dr. Upeka is a nutrition physician, now that Dr. Farrukh very clearly mentioned that we should take specific targeted interventions. So based on your expertise now, actually even both speakers mentioned about the obesity, and would you like to comment about the childhood obesity and how would you recommend these kind of targeted actions?
Thank you, madam. As we got a lot of kids from the school medical inspections, a lot of kids from diagnosed childhood obesity. When we get the history, what we learn is like there's a high consumption of SSB, sugar sweetened beverages, even from the school canteen. School canteen, there's very unhealthy food available. So we can't address what we, like when we take the 24-hour dietary call, what they say is they go to the canteen and eat some parathas and like with some dal curry. That's for lunch. So the other thing is there's no time for them. There's no time slot allocated for them to do physical activities at school. So like even I know, even my kids are also going to government schools, like no time slot for physical activities. So these two to be addressed, otherwise like we get a lot of patients from a lot of kids with childhood obesity, even with high fasting blood sugar levels and lipid profile levels. So I'd like to highlight that.
Thank you, Dr. Upeka.
Yes, I was, now that a lot of policymakers are here, I'm just thinking, I know that you all have done an enormous amount of work that most countries has not done. And we were the first to come up with the NCD policy in the region and perhaps internationally also. And then a lot of professional colleges, I had also been involved, and the nutrition physicians, endocrinologists, physicians, and lot of, but I think we need to now go for some like legislative, and also the other thing like the incentive, giving incentives for both, perhaps, maintaining targets for people. Some sort of different approach is, I think, needed along with what we had been doing to get some major action. Otherwise, diabetes is 23%. When I started researching on diabetes, 10%. So we are failing. I think we need to take some different approach.
Can I comment, Prasad? Based on my policy experience, and actually now we are developing the next 10-year health policy, 2026-2035. So it's very relevant that our speakers also presented about the risk factors and also about the premature mortality, morbidity, etc. But now it's time that we go beyond screening. We successfully established NCD screening, and it's available throughout the country. It's been more than a decade now. But this is the time that we should target more on health promotion, and especially in terms of well-being. The new national health policy is going to be called the National Policy for Health and Well-being, where we focus more on community awareness, empowerment and engagement. I think Prasad also mentioned about that need. So screening would be the next step, and I really appreciate the fact that you talked about screening related to government programs such as Aswasuma. So maybe this is the time to make screening mandatory. Samiddhi, we all have been trying to make it voluntary, but people are not coming. This is the time to make it voluntary, and also maybe like the Well Woman Clinic program, make it at two age cohorts, 35 years, 45 years. When a person becomes 50 years, so we are well aware about the indicators. So from the policy perspective, this is what we are going to do. While continuing screening, Dr. Samiddhi, it's time that we go a little early to an earlier stage, like health promotion, and also advocate people, make people aware for maintaining their well-being. That's my thought. Pujitha, you have any?
No, I don't think there is. Because of the interest of the time, we will now wind up this session. And thank you very much for the speakers, as well as the panelists, as well as Angela joining from India. So thank you very much. And we will adjourn this session.
May I now invite our chairpersons to award the certificates and letters of appreciation to the speakers and panelists. Could I now please invite Professor Prasad Katulanda to award the certificates and letters of appreciation to our chairpersons.
because